Hello, everyone. My name is Emily Romney, and I'm the Community Education Manager with the Myotonic Dystrophy Foundation. I am so excited to welcome you to our Ask the Expert webinar for today on gastrointestinal considerations for myotonic dystrophy. Before we begin, I'll start with a little bit about the Myotonic Dystrophy Foundation. We envision a world with treatments and a cure for myotonic dystrophy. Our mission is community, care, and cure. We support and connect the myotonic dystrophy community. We provide resources and advocate for care. We accelerate research toward treatments and a cure. MDF is here to support you. We have toolkits and publications, which include resources for care providers and families, such as the DM in the Heart Community Guide, Anesthesia Guidelines, the MDF Toolkit, clinical care recommendations, as well as resources for clinicians and researchers, including grant funding opportunities for DM research. We also have support groups led by trained community volunteers, which create a safe space to network, learn, and share. Our digital academy is a place where you can view hours of educational and inspirational videos by DM experts on demand. You can find all of our upcoming support groups, conferences, webinars, and more on our calendar of events on our website. We would also love for you to stay in touch with us. You can follow us on social media to make sure you are up to date on all things MDF and DM. You can find us on Instagram, X, Facebook, and LinkedIn. MDF is very excited for our 2025 conference in Indianapolis, Indiana from May 2nd to the 4th. Registration for the conference is now open. Be sure to check out the MDF discounted hotel block, the detailed community session listing on our website, and our new Sunday morning workshops. You can learn more about the conference and register on MDF's website. I also want to highlight a few exciting upcoming events. Our next Ask the Expert webinar will be on November 15th at 12 p.m. Pacific time. We are thrilled to hear from Drs. Hamill and Thornburg on DM and reproductive health. You can register for that webinar on our website. MDF is also hosting a Meet the DM Drug Developers webinar on November 22nd, 2024, and you can register now to participate. We would like to thank our sponsors of this webinar series, Avidity Biosciences. Thank you all for joining us today from around the world. Today's program will be an Ask the Expert webinar, which will feature a presentation from Dr. Sonu, followed by time for Q&A. We ask that you use the Q&A function to ask your questions. They will be sent directly to Dr. Sonu. We will do our best to answer as many questions as we can. To ask questions, click the Q&A button and type your question into the text field and click send. You can send questions anonymously if you prefer. Without further ado, I am pleased to introduce Dr. Irene Sonu. Dr. Sonu is a gastroenterologist and clinical associate professor of medicine for gastroenterology and hepatology at Stanford Medicine. Dr. Sonu is passionate about gut health and strives to provide the best care for her patients. She specializes in complex motility disorders of the gastrointestinal tract. Her areas of clinical expertise include achalasia, dysphagia, eosinophilic esophagitis, gastroesophageal reflux disease, gastroparesis, functional dyspepsia, irritable bowel syndrome, and pelvic floor dysfunction. Now, I would love to welcome Dr. Sonu.
Thank you so much for your introduction, Emily. I'm really excited to be here. I'm just going to go ahead and share my slides. All right, so I'm going to go ahead and get started. So as you know, I'm a gastroenterologist. I'm going to be giving a talk today on the gastrointestinal manifestations of myotonic dystrophy, both type 1 and type 2. And I have no relevant disclosures. So I want to start off by providing some background. And overall, unfortunately, there's very little published research on the GI manifestations in both types of myotonic dystrophy. There was one registry that actually collected over the course of 5 years the symptoms in 913 DM1 patients and 180 DM2 patients, which is a study that I'll be quoting a lot in the next following slides. Most of the information was collected through patient-reported questionnaires. And this table on the right is a comparison of the characteristics of those that participated in this registry. Just going through this slide, just to provide you some background, the average age of those with DM1 enrolled in the registry was about 45, and for DM2, they're a little older at the age of 54. The average number of years since the onset of the patient's symptoms was 18 for DM1 and 19 for DM2. So these patients in general had longstanding symptoms for the most part. The body mass index of these patients were pretty similar, around 25 to 26. The sex distribution was a little over half female for the DM1 group and 62% female for the DM2 group. And then the minority of the patients in this registry in general were cigarette smokers. Majority of those enrolled in this registry had DM diagnosed via genetic testing. So what this registry found was that the vast majority of patients suffered from at least one GI symptom. So you can see here, when you stratify based on DM type, 79. So the vast majority of patients with DM1 suffer from symptoms, and then 77. So over 3/4 of patients with DM2 suffer from GI symptoms. For the most part, people did not have any GI symptoms at the initial onset of their DM disease. You can see here only 1% experienced GI symptoms at the onset, and 0 reported any GI symptoms at the beginning of their disease. Why do people with DM get GI symptoms? Well, unfortunately, we don't really have a good understanding as to why people with myotonic dystrophy develop GI symptoms. It is thought, though, that the underlying muscle weakness and dysfunction that occurs with myotonic dystrophy can affect the smooth muscle of the GI tract. So this is a schematic taken from a review that was published relatively recently that illustrates the muscular layers of the gastrointestinal tract here. There are 2 different types of muscle. There's an inner circular muscle, which squeezes the muscles and decreases the diameter. And then there are these outer muscles of the GI tract, which shortens, which is makes the muscles kind of look like an inchworm. And it's that coordination of that inner circular muscle and that outer longitudinal muscle that leads to what we call motility of the GI tract, or digestion, or otherwise known as peristalsis. This allows for what we eat to move forward inside our GI tracts. There are, in addition to these muscles being essential, there's of course neurons or nerves that are responsible for coordinating these movements and allowing for motility to occur. And what's interesting about the GI tract is that, of course, the GI tract relies very heavily on the nervous system of the brain, but the GI tract also has its own nervous system that's called the enteric nervous system. So some of us refer to it as our brains being the big brain and the enteric nervous system being the little brain of our guts. It also relies heavily on something called the autonomic nervous system. And so what that is a part of our nervous systems that's comprised of something called the sympathetic nervous system. And that's the type of part of our nervous systems that gets revved up when we're under a lot of stress, like we're getting chased by an animal. And then there's a complementary part of our autonomic nervous system called the parasympathetic nervous system. And that is the part of our nervous systems that's activated when we're hanging out and resting and digesting. And so in order for digestion to normally occur, we need to have normal activation of our parasympathetic system and just an overall good balance between those two different parts of our autonomic nervous system. In addition to nerves and muscle, in order for us to have normal digestion, there are other players, including hormones that our body releases, our gut microbial or by bacterial composition called our gut microbiomes, and then, of course, the contents of what we eat on a daily basis. And so on the right here on this slide, you'll see the list of the GI organs that, that can develop disease or symptoms in the context of having myotonic dystrophy. And I'm going to discuss all these various conditions at length today. Before I do that, I wanted to refer back to that registry, where people were asked what type of GI symptoms they were experiencing. And you can see this bar graph has two different colored bars. Purplish blue here is DM1, and the yellow is DM2. And you can see here that the most common GI symptom in DM1 is trouble swallowing. This is otherwise known as dysphagia. The most common GI symptom in DM2, you can see here, was constipation. But you can still see for both of these symptoms, the other type of DM was commonly experiencing these symptoms as well. In addition to trouble swallowing and constipation, you can see that both DM types experience a lot of acid reflux. And then you also see other GI issues like gallbladder problems, liver problems, which can include fatty liver or having inflammation in the liver, or that can be seen in when you get your liver enzymes checked, or you can have stomach ulcers form as well. Other symptoms that were not included on this graph, but are definitely present in patients with myotonic dystrophy include irritable bowel syndrome, abdominal pain, fecal incontinence, and then diseases of motility. So there's one that I'm going to talk about today that's called gastroparesis, where your stomach is moving too slowly. And then there's one where your small intestine moves too slowly, called chronic intestinal pseudo-obstruction. And then lastly, when your colon moves too slowly, that results in constipation, and that's otherwise called slow colonic transit. And then just a couple more slides before I do a deep dive about those symptoms. What I found was interesting is that, again, for DM1, when people were enrolled in the registry, the most common issue was trouble swallowing. And this column here just shows that the number or the percentage of people that didn't have any GI symptoms. This column here shows the number of patients with DM1 that went on to develop GI issues. And again, the most common issue was trouble swallowing. But what was a close second was, interestingly, the development of stomach ulcers. For DM2, it was similar to what I had mentioned in the graph, the bar graph. So constipation was the most common issue that was people were experiencing at the time that they enrolled in the registry. But the most common, and then it was also the most common symptom experienced that people were to develop over that 5-year period. But then the second most common really being trouble swallowing, and following that is acid reflux. What's unfortunate, though, and was striking in this study, was that a lot of people, even though the vast majority of people suffer from GI symptoms, very few of them are actually taking medications for their symptoms. So this graph here breaks down the percentage of people that were taking actual medication for their GI issue. And only about 22% of DM1 and 19% of DM2 patients were actually taking reflux or heartburn medication. And only 4% and 10% were taking constipation medication. So based on this table, to me, I interpret this as people really not getting good treatment or maybe not even seeing the right kind of doctor to get their treatment for their gastrointestinal symptoms. So now let's do a deep dive and talk about each of those individual symptoms that people will develop. So we talked about trouble swallowing, which is otherwise known as dysphagia. And what that means is you have the feeling like food or liquid is getting stuck in your food pipe. The common symptoms that are associated with dysphagia are choking, coughing when eating, aspiration, which means you're getting food in your lungs. And that can be quite serious because that can lead to pneumonia developing, especially if you aspirate over and over again. Other symptoms include regurgitation, chest discomfort, and the need to chase food with water. It is common that dysphagia can also lead to heartburn or be associated with heartburn as well. I just want to touch upon the act of swallowing. And so when we think about swallowing, as gastroenterologists, we think about the two different phases. The first phase of swallowing is called the oropharyngeal phase, and that's a voluntary act where we're trying to transfer food from our mouth into our food pipe, our esophagus. And so this yellow right here is actually representative of food, and you can see that it requires a lot of action of our tongues moving this food backward and pushing against our palates so that it can go down. And at the same time, there are certain muscles or valves that will move so that food will not go up into our nasal sinuses, and then food that won't go down into our windpipe. You can see this is called the epiglottis here, and that goes down and covers our windpipe here so that food can seamlessly get into our food pipes, our esophaguses. In order for that to happen, there's also a muscle down here called the upper esophageal sphincter that needs to open up and relax to get that food down. That brings us to the next phase of the swallow, which is called the esophageal phase. So the first phase is more of a voluntary action, right? We have control over that, whereas the esophageal phase is an involuntary reaction where once your food enters into your food pipe, then the esophagus will work its magic to bring it down into the stomach. And that requires relaxation of that sphincter that I talked about, that upper esophageal sphincter. But you also have a sphincter down at the bottom called the lower esophageal sphincter. And that also can stay closed with the help of your diaphragm, right, lining up with it. In addition to those sphincters opening up, you need to get the food down. And there's some muscle contractions of the esophagus called peristalsis that occurs that can push that food down so it seamlessly gets into the stomach. So it's even though the esophagus seems like a very simple tube, it actually works in a very complex, coordinated fashion to be able to get our food down. And so what can lead to dysphagia? So moving on, again, there's very little research investigating why people get dysphagia in the context of having myotonic dystrophy. But the thought is that there's a possible mixture of weakness in the types of muscle in the esophagus. So the esophagus is made up of skeletal muscle and smooth muscle. And so, but the other thought is that maybe it's also not just a muscle problem, but maybe there is nerve weakness that is associated, that is causing this trouble swallowing. And so what we do know is that either phase, so that first phase, or the second phase of swallowing can be impacted in people with myotonic dystrophy. Usually when you have issues with the first phase, you'll experience more choking because you're also coughing a lot because you're getting things into your food pipe. Whereas when you have symptoms concerning for the second phase of the swallow being impacted, you'll have a feeling like food is getting stuck in your neck or your chest and you have to bring it back up or chase it down with water. So how do we evaluate that? Well, whenever I'm worried that someone has a weakness or issues with the very first phase of the swallow, then I want to have a speech therapist evaluate that, or an ENT. And they usually conduct 2 studies, or just one of them if it's sufficient. One involves x-rays where you swallow a bunch of different liquids and different thicknesses of solids, and they take x-rays as that food goes down and sees if any of that's getting into the windpipe. So that's called a modified barium swallow study. The second test is called a FEE study, where they take a tiny little scope and they put it down your nose and they watch your swallowing as this camera is kind of near the top of your food pipe, right before it enters the esophagus. And they see if whether or not certain foods and liquids are going into your windpipe instead. And based on the results, the speech therapist or the ENT can determine what the next step should be in treatment. When there is more concern for the second phase of swallowing, that's where I come into play. As a gastroenterologist, one thing I do frequently is I do something called an upper endoscopy, where I take a camera while the patient is asleep and I go down the mouth and I do a very careful inspection of the esophagus. I also just routinely look at the stomach and the beginning of the small intestine as well. And I look for whether or not there's narrowings, whether or not there's signs of severe inflammation, whether or not there's signs that there may be severe damage from conditions like reflux that may be contributing to the difficulty swallowing. In addition, we oftentimes will order an X-ray study where, very similar to the modified barium swallow that I just mentioned, but instead of focusing on the beginning of the swallow, and a radiologist would take a bunch of pictures as you swallow liquid barium, and they look at how the barium goes down the esophagus and see if there's coordinated muscle function there, and sometimes they'll also see whether or not there's a discrete narrowing that's causing delays in the passage of the barium. The best way, though, to look at muscle function, motility of the esophagus, is this test on the right here. It's called an esophageal manometry, where a catheter will go down the nose that has a bunch of pressure sensors along it, and a patient will swallow water about 20 times and then look at whether or not the muscles of the esophagus are firing normally. Sometimes they can be weak, sometimes they can be too strong, and that's what causes the dysphagia symptom. So the treatment of dysphagia is really focused on what the primary driver is. And, the treatment can vary, from dietary changes, getting speech therapy, to getting me to stretch out the muscles with a balloon during an endoscopy, or getting surgery or injecting Botox in the esophagus to try to relax it. Moving on, I want to talk about reflux. So GERD, it stands for Gastroesophageal Reflux Disease, otherwise known as heartburn, otherwise known as acid regurgitation, acid reflux. And as I mentioned earlier, sometimes you can get difficulty swallowing in the context of having GERD. So heartburn and acid regurgitation are by far the most common symptoms, but you can also get these atypical symptoms where you get pain with swallowing, coughing. Globus sensation is where you feel fullness in your neck all the time. Or when the acid goes all the way up to your vocal cords, it can cause inflammation of your larynx or even erode your dental enamel. So why do people get reflux of acid from their stomach into their esophagus? Well, there's a lot of different reasons why, but the most common issue is that lower esophageal sphincter that I talked about earlier just opens up too much, and that allows passage of that acid to go up into the esophagus. That could be due to a variety of issues, including the presence of something called a hiatal hernia, which is illustrated here on the right, where some of your stomach may be move upwards above the diaphragm. So you no longer have that diaphragm here that helps keep your lower sphincter closed. And you can get this little pocket of stomach where acid can build up and reflux more easily into the esophagus. You can get a variety of motility disorders that can lead to reflux, or you can have conditions where you don't make enough saliva in your mouth, and that can lead to an impairment in the clearance of acid, because saliva helps clear away any extra acid, residual acid that may reside in your esophagus. So how do we diagnose reflux? Well, as I mentioned earlier, we do a lot of endoscopy and GI, and when people have pretty severe reflux, it can look like this, where it's really red and angry from all that damage that acid has caused on the esophagus. And sometimes that damage is so severe that it can narrow down the esophagus and make it hard for food to go down. Fortunately, the majority of people don't have severe reflux. And so their esophagus looks completely normal. And then in that circumstance, then we move on to do something called pH testing that will measure the esophagus pH for either a 24 or 96-hour period and that measures how much acid is going up. How do we treat reflux? Well, in very mild cases, simply cutting out acid, caffeine, alcohol, things like that can really make a big difference. I forgot to mention on the slide, not smoking, because smoking is associated with reflux. Being overweight can add a lot of pressure to your abdomen, and that can lead to reflux as well. So in certain patients, weight loss can be encouraged. If you have a lot of reflux at night, then you may benefit from sleeping with a wedge pillow, so you're a little bit more elevated. Also, studies have shown that if you sleep on your left side, that actually improves nighttime reflux as well. A lot of people, though, do require more than just lifestyle changes. And thankfully, a lot of these medications are safe. They're easy to obtain because they're over the counter. And the best drugs we have on the market are something called PPIs, proton pump inhibitors. They are the best drug and what they do is they decrease how much acid your stomach makes so that there's less acid going up into the esophagus. For very mild cases of reflux, you can use an antihistamine. It's not as potent as PPIs, but also similarly decreases acid production. And then in very mild cases, you can use antacids like Maalox, Tums. I personally like something called sodium alginate that's been shown in studies to bind to acid and reduce how much acid can go up. In more severe cases, then especially when medications do not provide any relief or patients do not respond to the medications at all and they still have persistent damage to their esophagus, then surgery may have to be considered. Moving on, we're going to talk about gallstones. So some of you may be familiar with what these are, but you have a gallbladder here that is close to your liver, and every day our liver makes bile, and it goes down these bile ducts and gets stored in the gallbladder. And every time you eat fat, then the gallbladder will squeeze out the bile and it'll go down into your bile ducts and go into your intestines to help absorb and digest that fat. So the thought is that in DM, there is poor gallbladder contraction, potentially because of muscle involvement of the DM. And that can make it harder for bile to empty out of this gallbladder, and stones can form as a result. The classic symptoms of gallbladder disease is people getting severe pain in the right upper quadrant after eating a fatty meal. So it's not constant pain, it's just intermittent pain. When there is a gallbladder stone that's obstructing the ducts here, then that can lead to an infection. And in more severe, so that's a more serious case, and that can lead to the development of fever. And usually patients have to go to the emergency room to get that addressed because there's an obstruction and a gallbladder needs to be removed more urgently. Whenever there is a suspicion for gallstone disease, the recommendation is to get an ultrasound or a CT scan. And then if gallstones are confirmed to be the cause of patient's symptoms, then surgery to remove the gallbladder. Let's move on to the stomach now. So I mentioned earlier that in DM patients, it's really common to have slow motility. And when you have slow stomach emptying, that's called gastroparesis. So paresis meaning like paralyzed in the stomach. The classic symptom of gastroparesis symptoms are nausea, vomiting, fullness, bloating, distension, early satiety, meaning getting full just after a few bites of a meal, pain. And because of these symptoms, a lot of people don't eat as much as they used to, and then that results in weight loss. Normally, whenever we eat, the stomach should do two things. It should start expanding and relaxing to allow us to eat a big meal until we're full. And then once we're done eating, then it should start churning and breaking down that food and emptying it into the small intestine. You have a muscle here called the pylorus that will open up to allow all that broken down food to enter into the small intestine. The thought is that in people with gastroparesis, there's failure of the stomach to relax very well, which is why people get full so quickly, that early satiety. And there's also failure of the stomach to be able to churn and break down that food so that it doesn't empty. The other thought is that the sphincter muscle here, the pylorus, may not be relaxing all the way. And that's why food can be sitting in your stomach for hours or sometimes even days. The way that we diagnose gastroparesis is the most common way, that is with something called a gastric emptying scan, otherwise known as gastric scintigraphy. It involves you eating a meal that has a tracer in it, and the radiologist will trace how long it takes for that meal to empty out of your stomach. Normally, 90+% of that meal should be gone by 4 hours. But of course, on a day-to-day basis, that changes, right? It really depends on what you eat and the size of the meal, right? But based on this standardized meal, a 90+% should be gone by the 4-hour mark. So if you have less than that retained in your stomach, then that's positive for gastroparesis. The first line intervention to treat this condition is to change your diet. Eating small meals that are smaller in particle size. So what that means is eating more soft foods, eating more smoothies and soups have been shown to decrease symptoms associated with gastroparesis, in addition to lowering the fat and the fiber content of foods, because fat and fiber tend to sit in the stomach longer and can contribute to that early satiety. Sometimes we do use medications. The most common ones are called prokinetics. Those are drugs that help enhance the emptying or the peristalsis. And we use a lot of anti-nausea medication because nausea is definitely by far the most common symptom associated with gastroparesis. In more advanced cases, here at Stanford, we're a tertiary care center, so we do offer these more advanced procedures. There's a surgery that you can do for gastroparesis, and then in patients with very severe nausea, there's a gastric electrical stimulator that we sometimes will have our surgeons here place to alleviate that nausea. Moving downwards to the small intestine, when you have poor motility of that organ, it's called CIPO, chronic intestinal pseudo-obstruction, otherwise known as small intestinal dysmotility. Sometimes people with CIPO will also concomitantly have colon involvement as well. And it's usually quite striking on imaging, which I'll show you in the next slide, because it can look like a mechanical obstruction, otherwise known as an SBO, small bowel obstruction. The symptoms are also very similar to both gastroparesis and to symptoms of a small bowel obstruction. You can get nausea, vomiting, fullness, bloating, distension, early satiety, abdominal pain, and weight loss. And because of this poor motility, this can lead to a lot of malabsorption as well. And so the way that this is diagnosed is you can actually diagnose it with a variety of ways. This is something called an upper GI series. It's done in the radiology department, very similar to that barium esophagram that I explained in the esophageal section, where you drink some barium and then the radiologist would take a bunch of pictures of that barium entering your small intestine. And I know it's hard to appreciate in this image because I don't have an image of what a normal small intestine looks like. But what they'll see is that the small intestinal walls are very stretched out, or what we call dilated, and throughout, and that's because there's very little movement or motility throughout the small intestine. And so oftentimes patients will be mistakenly diagnosed with a small bowel obstruction. The key to treatment is honestly to do less. And by that, I mean to avoid surgery, because a lot of the time patients will mistakenly be diagnosed with a small bowel obstruction and undergo unnecessary surgery. Changes to the diet, very similar to the gastroparesis diet, are recommended. Oftentimes, patients, though, will need some additional nutritional support, including IV nutrition, especially in more advanced severe cases of malnutrition. In terms of medications, it's very similar to the medications that we use for gastroparesis, but there's this other issue where people will get an overgrowth of bacteria in the small intestine that will lead to a lot of severe diarrhea, and that can be treated with cycling antibiotics over and over again. Moving downwards to constipation, to the colon. So what is constipation? It's not just about how often you go, but the technical definition is having less than 3 bowel movements per week. But you can still have bowel movements every day and still have constipation, especially if you're passing very, very hard stools. They're called a Boston stool forms, Boston scale forms. I'm sorry, Boston scale for form stool 1 and 2. I'll show you a picture of that in a later slide. Or you can have the feeling of incomplete evacuation, straining, difficulty defecating, or having to use digital maneuvers on a regular basis. That's all constipation. So there are many different causes. One of the most common causes is that your colon just moves slowly. That can be a result from a variety of problems. It could be just age, unfortunately, in and of itself, or it can be from, not moving as much as you used to. Of being in a wheelchair, being bedbound can definitely lead to slow transit. And this is how you can confirm slow transit, which is where you get an X-ray, you swallow a bunch of these pills, and 5 days later on the X-ray, if there's still a lot of these little markers, they're called SITS markers, then that would be positive for slow transit. The other issue that's very common is something called pelvic floor dysfunction. So normally every time we need to poop, you have these muscles inside your pelvis that should be relaxing very seamlessly, that allows the rectum to be able to straighten out, and the anus should be relaxing too, so that poop can seamlessly get out of your rectum. But when people have pelvic floor dysfunction, they lose that coordination of these muscles, and it makes it harder for the poop to come out. And so this can be diagnosed with testing such as it's called a manometry with a balloon expulsion test, or an MRI that's called a defecography test. Fortunately, whenever this condition is diagnosed, the vast majority of people do get a lot better with physical therapy. In addition to that, exercise, of course, can really help. Hydration. And then there's something called a squatty potty that I am a huge fan of. So that really helps enhance your what we call the puborectalis muscle, so that it's easier for that muscle inside your pelvis to be able to relax, and it helps having your feet on the squatty potty also allows for the rectum to straighten out more easily and for poop to come out more quickly. In addition to that, I'm a huge, huge fan of fiber. Fiber can be used for both constipation and diarrhea. I'm a big fan of soluble fiber supplements such as Metamucil, which is psyllium, wheat dextrin, which is benefiber, and methylcellulose, which is Citracel. These all create more bulk to the stool so that it's more smooth, more regular, so it can be used for both constipation and diarrhea. I would avoid insoluble fiber like all brand cereal, Fiber One bars, because they contain too much roughage and can cause a lot of cramping and discomfort. Beyond fiber, I'm a huge fan of over-the-counter laxatives. I'm not going to go into detail about all the different brands here, but as you can see, there's many different options. But also just want you to be aware that there's actually a lot of prescription laxative options, and there's even a vibrating capsule that we'll sometimes prescribe to patients, and it will basically vibrate through the colon and help move that stool along. Moving on to diarrhea, the most common cause of diarrhea actually is constipation. So what that means is that you get so backed up with stool that the only thing that can come out is liquid stool, and that's called overflow diarrhea. So to diagnose that is really involves just a simple X-ray to see if you're impacted with stool. I had also talked about small intestinal bacterial overgrowth in the context of having slow small bowel motility, and that can commonly cause diarrhea as well. And so that's diagnosed with a breath test and treated with antibiotics. There are many other causes of diarrhea as well. These are not particular to DM patients. These are just common causes in general. But there's bile acid diarrhea, and more common in people that don't have a gallbladder, and they'll get really bad diarrhea, especially with fatty meals. And then there's something called fat malabsorption that can be from a variety of conditions, such as pancreatic disease, liver disease, as well as small intestinal disease. When people suffer from a lot of constipation and diarrhea, that can lead to leakage of stool, otherwise known as fecal incontinence. And having poorly controlled diarrhea and constipation are by far the most common issues associated with fecal incontinence, but it can also be due to a weakening of the anal sphincter so that it's not tight anymore and able to keep the stool in. It's also commonly associated with that pelvic floor dysfunction that I mentioned earlier, because you have poor coordination of the muscles down below, so that it's stool can get impacted and then liquid can leak out of the anus. When people have alterations, so constipation or diarrhea or a mixture of both of their bowel habits that's associated with abdominal pain, then that's called irritable bowel syndrome. Irritable bowel syndrome is common in the context of having myotonic dystrophy, but it's also just common in the general population in and of itself. And I talked about that Bristol Stool Form Scale earlier, the BSFS, and this is just a schematic of what it looks like. When people have more constipation, they usually have a low number. They have rock hard stools, type 1 or 2. When they have more diarrhea, then it's usually a high number, and it looks like 6 or 7. In addition to controlling the diarrhea and the constipation with fiber, laxatives, antidiarrheals for diarrhea, you can also consider trialing a diet. I don't endorse this as a long-term strategy. I think this is a good strategy to embark on if you're having a flare of IBS symptoms, and this can help shorten the duration of the flare. But there's a very popular diet called the low FODMAP diet that reduces certain sugars and proteins that can cause a lot of gas formation and IBS symptoms. And so actually, if you Google Stanford low FODMAP, you'll be able to see our handout very easily. In addition to diet, I'm a huge fan of exercise. I'm a very, very big fan of highly concentrated peppermint oil capsules. That has been studied as an intervention that can help with the spasming pain. It can also help with bloating and distension, and it's over the counter. There are prescription antispasm pills, but they just tend to not work very well. The other therapy that's very important for IBS is gut-brain therapies. The reason being is that the gut-brain connection is almost always overactive in patients that suffer from IBS. And so there's a lot of ways that therapy can be initiated. There's smartphone apps. Of course, there's therapists that can be seen. I'm very thankful to have a GI psychiatrist, a licensed social worker, and a GI psychologist all on faculty here with me that I can direct my patients to see. But there's also lots of great medications that can really help with the gut-brain therapy, gut-brain connection. In addition to that, I'm also a huge fan of mindfulness practices, more Eastern practices like acupuncture as well. So in conclusion, gastrointestinal symptoms are common in those with both types of myotonic dystrophy. Early diagnosis and treatment are important for improving quality of life and preventing complications. Ask your care team for a referral to a gastroenterologist to discuss symptoms. Thank you.
Thank you for that informative presentation, Dr. Sonu. We will now transition to the Q&A portion of today's webinar. Just as a reminder, we do ask that you use the Q&A function to ask your questions, and they'll be sent directly to Dr. Sonu. We will do our best to answer as many questions as we can. To ask questions, click the Q&A button and type your question into the text field and click send. You can also send questions anonymously if you prefer. So we will now open the floor for questions from our attendees. First question I have for you, Dr. Sonu, is how can someone work with their primary care doctor or a specialist to ensure that the GI issues they're experiencing are properly addressed, even if they're unfamiliar with DM? For example, are there specific terms or concepts that they can communicate with their doctor so that they understand the issue?
That's a great question. I think it's important to provide an accurate description as well as you can to your doctor in terms of what the specific symptoms are. I think that a lot of the conditions that I described today are actually very common, even in the general population. Like I said, irritable bowel syndrome, for example, with constipation or diarrhea, it affects millions of people actually in the United States and worldwide. So the most primary care physicians are actually very equipped to be able to manage and treat those types of conditions. When there's more advanced symptoms, for example, dysphagia, that usually should involve a referral to a gastroenterologist because that almost always warrants further diagnostic testing because, of course, it's important to know what's causing the dysphagia, the difficulty swallowing. I wouldn't make any assumptions, like nothing needs to be done. Just chew more thoroughly. There always should be some kind of diagnostic testing that should be pursued to figure out which part of the swallow is affected, if any, and what kind of interventions, should be made to really address what's impaired. And then lastly, I just want to touch upon reflux because I do think that oftentimes patients will think that they're having reflux, but it can all be derived from a motility disorder. And so I think it's reasonable, though, since a lot of the great reflux medications are available over the counter, I think it's reasonable to start off with your primary care doctor by just treating reflux before pursuing any diagnostic testing, because the PPIs in particular, the Nexium, the Prilosec type drugs, they're so effective that if the symptom truly is from reflux disease, then you will benefit from those medications. 60 to 90% of people with true reflux are going to get relief with those GERD medications. And if the patient doesn't improve with those symptoms, then that definitely warrants a referral to a gastroenterologist to get evaluation for other conditions like a motility disorder. Or it could be that the medications are not strong enough, and surgery or other things need to be pursued.
Great, thank you. That's super helpful information. Speaking of surgery, someone asked. They said, "I'm having heart surgery in the next couple of months and suffer from chronic nausea that is controlled with meds. In addition to the anesthesia guidelines for DM1, is there anything additional I should make sure the anesthesia team is aware of to control this?"
Yes. Great question. I'm glad that you're already getting relief of your nausea with the medication. I do think it's important to note, especially in this new era that we're living in, where there are a lot of medications that cause nausea. And what I'm referring to actually are these very popular diabetes and weight loss medications called Ozempic and Wegovy. It's important to mention whether or not you are taking those medications to the anesthesiologist before pursuing the surgery, because they may want you to be on a modified diet prior to the surgery if you are on those. The reason being is that what those drugs do is they slow down your motility and they give you gastroparesis, which is one of the reasons why it's such an effective medication for weight loss, is because it really contributes to that early satiety that I talked about in people that have gastroparesis. And so if you do have nausea from being on those medications, the anesthesiologist may want you to hold, one dose of it, or may want you to be on a clear liquid diet, for a certain amount of time before the surgery, just to really ensure that there isn't a ton of food in your stomach at the time of your surgery. If you're not on any medications that are causing nausea and there's really no good reason, obvious reason that you have nausea, then I do think it's worth considering getting some testing done before the surgery, like a gastric emptying scan. But nausea can be from a variety of things. It's not always from the GI tract. Whenever I think about nausea, I think about the brain, I think about the inner ear. because vertigo can cause nausea, brain, migraines, a variety of things in the brain. And then, of course, gastroparesis, like I talked about, or any of those motility disorders, like I talked about. And so it's always good to do an evaluation just to really figure out what the source is before kind of jumping to a big surgery.
Yeah, that's great. Thank you. Next question. This person says, I have what starts as severe gastroparesis. My stomach may not release for days and only empties very slowly, if at all. This changes overnight into a condition that my body drops food almost directly into the small intestine, and food in many cases is through the body in less than an hour. This turns into a crazy vicious cycle where I become extremely ill and start dramatic weight loss, which turns into significant muscle loss. I cannot take anything for gastroparesis because it starts the rapid emptying of the stomach. Any suggestions?
Great question. So it's hard to sometimes know what the underlying, like the more common driver is, because gastroparesis, like I mentioned, focuses on having slow emptying. But then there's a condition that I didn't talk about today. And to my knowledge, I'm not sure it's that common in DM, but it's something called dumping syndrome, where your stomach is moving too quickly. And the classic symptoms of dumping is when a patient will eat a very kind of sugary or simple carbohydrate meal that doesn't contain a lot of fiber, for example, and you'll get an immediate dumping of that food into the small intestine, which leads to diarrhea. And then because of insulin release, you'll actually abruptly get symptoms of low blood sugar, so hypoglycemia. So you might feel lightheaded, jittery. So both gastroparesis and dumping are primarily managed with diet. So I do think it's important to get an assessment with a gastric emptying scan to see what the underlying issue is, because then that'll determine what diet you may benefit from. Because when you have gastroparesis, as I mentioned in my slides, like you really want to focus on lowering your fat and fiber content, eating more small particle meals so that food can more easily enter into your intestines. But the dumping diet is actually the complete opposite. You want to eat more fat, you want to eat more fiber, you want to avoid all of those simple carbohydrates like white bread and white rice and stuff like that. And then to really avoid symptoms. So getting a diagnostic eval is really important.
Okay. Yeah, that makes sense. Thanks. This person says that they have a lot of issues with not being able to control their bowels. They love walking, but have not been able to walk outside as they need to use the bathroom at the drop of a hat. In the past, they've tried codeine, which worked quite well, but they have currently been prescribed colesevelam.
Yeah.
Yep, recently. And they're wondering if you think that may help their bowel issues. They haven't tried it yet.
Yeah, great question. So colesevelam, even I have a hard time pronouncing that one, is something called a bile acid binder. And so I talked very briefly about bile acid diarrhea as being the driver or one of the causes of diarrhea. It's more commonly seen in patients that don't have a gallbladder. But there was a study to show that up to 25% of people with bile acid diarrhea actually still have their gallbladder in place. And so there's in the United States, there isn't an easy way to test for bile acid diarrhea. So most practitioners, myself included, will trial bile acid binding medications like colesevelam to see if that helps. And it's a pretty harmless medication to try. Historically speaking, it was made to lower blood cholesterol, actually, but they just weren't as good as drugs compared to the pitavastatin drug. So it's not used very commonly to lower cholesterol, but there is that added benefit actually to being on that type of medication. And so if there is a suspicion that you have bile acid diarrhea, then I certainly think that it's worth trialing. It's a very safe medication to try with the guidance, of course, of your doctor. If you found, though, in the past that codeine worked the best for you, then there's probably a motility component that's causing your diarrhea. So what that means is that things may be going through you too very quickly. Your transit time is very fast. And so I'm not a big fan of codeine because it's a narcotic. So I usually start with Imodium, which slows down your transit time. And as you may know, Imodium is over the counter. And if that doesn't work, despite being on max doses, then I usually advance to a prescription antidiarrheal called Lomotil. And it works a little bit better than Imodium. I'm not a big fan of narcotics because, there can be dependence issues. And I think there's much safer options than codeine. So, just something to think about. Yeah.
Yeah, that's great. We are approaching time, so we'll get through as many more questions as we can. But someone asked, they talked about how their son has frequent diarrhea and has had that problem for several years. And after a gallbladder surgery and lots of tests, the problem still exists and they're not sure why. So he takes daily Imodium now, and that's helping a lot. But they're wondering if it's okay to take Imodium long term, especially without knowing the root cause of the problem.
Yeah, great question. Very commonly we don't identify the root cause of the problem, but the presumption is that your motility is really fast, right? And there's no easy fix for that. So we rely very heavily on Imodium type products to slow the motility down. It is safe as long as you're taking it as directed on the box at very high doses when people are using like 3 or 4 times of what's recommended on the box. So what's recommended is typically a maximum of 8 milligrams per day. So if people are taking much higher doses, then that can lead to heart issues. So you really want to avoid taking more than what's recommended. But in that patient's circumstance, it's always worth looking into whether or not bile acid diarrhea may be playing a role, because that patient sounds like doesn't have a gallbladder anymore. So, if you wanted to try something new, then you could try colesevelam or cholestyramine or cholestipol. Those are all those different types of bile acid binders, and see if that helps. And if that's helps, then it's likely that the diarrhea is more from a bile acid diarrhea issue.
Okay, great. Yeah. Along a similar vein, and we'll end with this question. Someone asked, is it okay to take OTC, acid reflux medications long term?
Great question. So I get that question probably about half a dozen times a day in my clinic. And I think because the media has really given primarily PPIs, those Nexium, Prilosec type drugs, a really bad rap. A lot of the scary long-term side effects have been based not on randomized controlled trial data, but more of what we call observational studies. So it doesn't necessarily prove causality that these drugs will cause dementia, bone disease, osteoporosis. That being said, you always want to make sure that you're on a drug, any drug, not just acid reflux drugs, but just at any medication long-term for good reason. So it's always good to question the diagnosis, see how you feel off of the medication too. Give yourself a holiday and see if you really need it. If you don't feel any different off of it, then you probably don't need it. You may benefit from pH testing to really measure how much acid is going up into your esophagus to see if you truly do have reflux and need to be on these medications long term. But at the end of the day, thankfully, there has been randomized controlled trials looking at the safety of these PPI drugs for a 3-year period, and they did not show any concern for heart attacks, like the kidney, it did damage and so forth. The one thing that was seen on that trial, though, is that there's a slightly increased risk of potentially getting a GI bug, like a gastroenteritis or food poisoning. And the thought is it's because you're making less acid, and acid kills off some of the bacteria that we eat every day, right, in fruit and vegetables. And so that's why people on these drugs may be at increased risk, but it's not even a 2-fold risk. It was about a 1.3 risk increase in that PPI group.
Okay. Yeah, that's really helpful. Thank you. And with that, I just want to say thank you to all of our attendees for their participation. And thank you again to Dr. Sonu for providing this Ask the Expert webinar. As a reminder, this webinar is recorded and will be sent out within the next week. And after the webinar ends, you'll be provided with an opportunity to take a short survey about today's program. We greatly appreciate you taking the time to provide us with feedback. Lastly, if this program spoke to you, please consider showing your appreciation by making a donation via our website. You can also get involved by joining the Myotonic Dystrophy Family Registry. Thank you all for joining today's webinar, and we'll see you next time.